Hello, good morning. It's me, Dr. Muhammad Naseem Shirzad, and today I'm going to start a series of lecture on urethra, the venous, and the various common disease like the Peyronie's disease, like the priapism, like the penile fracture, and like the urethral structure. But before going, I will little and quick review of the anatomy of the pelvis. The pelvis is composed of various layers, and it's starting from the skin. Outer skin, we will be having the superficial and deep fascia. The superficial fascia is called the dirtus fascia, and the deep fascia is called the bug fascia. The importance of bug fascia is that if the bug fascia is intact during urethral injury, I means like in bulbar urethral injury, if this bug fascia is intact, the urine will be just limited to the penis. But if any injury to this bug fascia occur, the urine will extravasate into the superficial perineal pouch. Then it can go into the scrotum, and then it can go into the interior abdominal wall. So this is the understanding of this bug fascia is important for this extravasation of urine during bulbar urethral injury. So after the bug fascia, the next we will be having two contractile bodies, which is called the corpus cavernosum, and below of that on the ventral side we will be having the urethra. The corpus cavernosum is surrounded by a tough layer of tissue which is called the tunica albugina. This tunica albugina is very important, and it is made of type 1 and type 3 collagen, and it consists of two layers. This tunica albugina is composed of two layers in the penis, but it consists of three layers in the testes. When it surrounds the testes, it composed of three layers, but when it surrounds the penis, it composed of two layers. The importance of tunica albugina is that this is the tissue, or this is the part of the pelvis which is get fractured during penile fracture. So when we are saying that there is a fracture of the penis or penile fracture, so this is the fracture of actually this tunica albugina. The second importance of the tunica albugina is that when we are saying that there is a Peyronie's disease, so what happens when there is a continuous irritative trauma to the this tunica albugina? It becomes fibrosed, or it becomes scarred, and it giving a hard tissue unpalpation, which is called the Peyronie's disease. So the Peyronie's disease is due to problem in this tunica albugina, and the penile fracture is the problem or the fracture of this tunica albugina. So this is important, and this tunica albugina is only and only surrounding the corpora cavernosa, the two corpora cavernosal body. It not covering the urethra. It is important. Secondly, this the corporal body is a truly hollow tubes, and when the erection occurs, the blood is accumulating in it. So this is all about the corpus cavernosa, which is a contractile tissue. Now coming to the urethra is surrounding by the corpus spongiosum, but this corpus spongiosum is only limited to the anterior urethra, I means the penile urethra and the membranous urethra. That's why the any of the narrowing of the interior urethra, we call it the stenosis, we structure, but when we call it stenosis, that is the posterior urethra. So in interior urethra, the narrowing is called the structure because of this corpus spongiosum. When this corpus spongiosum fibrosed, or when there is a urethral injury, so because of this corpus spongiosum, which is only surrounding the interior and interior urethra, I means the penile urethra and the bulbar urethra. So this was the whole anatomy and the various parts of the pelvis. Now coming to the blood supply of the penis and the urethra. So the main blood supply which is coming to the urethra is from the internal iliac artery, and from the interior division of the internal iliac artery we are receiving the internal pudendal artery, and this pudendal artery at the base of the penis giving the common penile artery, and this common penile artery is divided into three main branches. One is called the dorsal penile artery, the other is the bulbar artery, and the other is the urethral artery. We can also divide it into deep penile artery and bulbourethral artery, and these both artery get anastomosis at the tip of the penis, and this anastomosis of these both artery is important clinically. So it is running in a way that the deep dorsal artery is running over the dorsal surface of the pelvis, and this deep dorsal artery is running between the deep fascia, I means the bug fascia, and that of the tunica albugina. So it's located and it's running between the bug fascia and that of the tunica albugina, while the urethral artery that is running on the ventral side, as the urethra is located on the ventral side, and these both get anastomosis at the tip of the penis. And this dorsal penile artery and this corporal bodies, or the cavernosal body, or the cavernosal contractile tissue, is important, as when we are saying that the priapism, in priapism actually there is a problem, or either it is ischemic or non-ischemic, that is a separate discussion, but there is actually a pooling of blood in this corporal body, and it's not getting drained. So when it is not getting drained, it is accumulating for more than 4 hours, and we call that the priapism, in the absence of any sexual stimulus. And if it is persistent for more than 4 hours, and the blood is not evacuating from this corporal body, we call it the priapism. So it is important. Now let's discuss the urethra and the various part of the urethra. The anterior urethra, it is derived embryologically from the ectoderm, while the posterior urethra is derived from the endoderm. In female, the interior and posterior urethra, I means the whole urethra, is derived from the endoderm. So it is endodermal in origin in female. The urethra is divided into various parts, into various types. It can be divided into interior urethra and posterior urethra. It can be divided into proximal urethra or distal urethra. The anterior urethra we divide into two types. Number first is the penile or pendulous urethra, and the second is the bulbar urethra. The posterior urethra is divided into two, when one is the membranous urethra and the other is the prostatic urethra. This whole length of the urethra in male is 18 to 20 centimeter, while in female it is short. That's why the risk of infection in female is very high because of the short urethra. So in male the size of urethra is 18 to 20 centimeter, while in female it is just 4 centimeter, while the diameter of this urethra in male and female is 6 mm. This is the whole diameter of the male and female urethra. Now coming to the various size of the urethra, the penile urethra, we call it pendulous urethra, it is 10 centimeter. The bulbar urethra is 5 centimeter. The membranous urethra is 2.5 centimeter, and the prostatic urethra is 3 centimeter. There are some important clinical points which I want to add between these landmarks. Like, let first talk the prostatic urethra. The importance of prostatic urethra, that it consists of transitional urothelium. We also call it urothelium. It is the widest urethra, and it is the most dilatable portion of the urethra. Second, the ejaculatory duct is opening into the posterior wall of this prostatic urethra. The next is the membranous urethra. I have just started from the bladder neck. So the membranous urethra is composed of pseudostratified columnar epithelium, and the membranous urethra is the shortest urethra, which is 2.5 centimeter, and it is the least extendable portion of the urethra, and it is the second narrowest part of the whole urethra. Now coming to the bulbar urethra. Bulbar urethra having some important features. Number first, bulbar urethra is the commonest site for stricture. Number second, bulbar urethra is the commonest site for carcinoma of the urethra. The penile urethra is not that much exposed to the injury. Now let's discuss some extravasation of the urine in the injury of these various part of the urethra. In membranous urethra, if there is an injury into the membranous urethra, the extravasation will occur into the deep perineal pouch, and you can remember this just by a simple formula MUD mud. Mud mean when there is a membranous urethral injury, it will go into the deep perineal pouch. When there is an injury into the prostatic urethra, it will go into the superficial perineal pouch, and you can remember it by pus. Pus. Pus means prostatic urethra, S means superficial perineal pouch. While in case of the penile urethra, it is also same just like prostatic urethra, and it will go into the superficial perineal pouch and can be remembered by formula pus. And the second is the bulbar urethra, and the bulbar urethra, it is most commonly injured by falling on projecting object like bicycle, like falling on manhole covers, etc. And we have discussed that what will happen if the bug fascia is intact, or it will get damaged. So what will happen, we have discussed that in a detail. So now let's discuss the scrotum and the testes in detail. The various layers of the scrotum include from outside to inside. The first layer is the skin, the second is the dartus muscles, after that is the external spermatic fascia, and then the cremasteric muscle. After that we will be having tunica vaginalis and then tunica albuginea. The further classification of the tunica vaginalis, it is as it include the visceral inner layer and the parietal outer layer of the tunica vaginalis. And clinically and surgically it's important as the accumulation of the fluid between this visceral and parietal layer of the tunica vaginalis is called hydrocele. And when this fluid which is collected between these two layers, they become infected, we call it pyocele. And when that contain hemorrhage or when contain blood, we call it hematocele. So this is the clinical importance. And then the tunica albugina, this is the very tight layer, and this is the tough layer which is covering the testes, and this is the last layer. Now let coming to the blood supply of the testes. The blood supply of the testes, it coming from three main sources. Number first is the testicular artery, which is also known as the internal spermatic artery, and this is the main blood supply to the testes, and it is arise directly from the aorta, both right and left side arising from the aorta. It is also important to remember that the venous drainage is like the left renal vein is draining into the left testicular vein, or spermatic vein is draining into the left renal vein, while the right testicular or internal spermatic vein is draining into the IVC, which is just like opposite to that of the testicular artery. Testicular artery both on right and left side directly arising from the aorta. The second artery is the vas deferens, which is also called differential artery, and it is a branch of superior vesical artery, which is in turn is a branch of the internal iliac artery. Then the cremasteric artery, which is also called external spermatic artery, and this is the branch of inferior epigastric artery, which in turn is a branch of the external iliac artery. So this was all the blood supply of the testes. Now coming to the drainage, lymphatic drainage, the right is draining into the inter-aortocaval bodies, with some to the right paracaval and small amount to the para-aortic and precaval. The left side is draining into the para-aortic. So right drain into the inter-aortocaval and the left is draining into the para-aortic. And the overall lymphatic drainage is from right side to the left side. The tunica albugina in the test is composed of three layers, and it is made of type 1 and type 3 collagen. Now there are two main components of the testes. One is called seminiferous tubules, and the other is the interstitial tissue. The seminiferous tubule is 70 to 80%, while the interstitial tissue is 20 to 30%. There are around 600 to 1200 seminiferous tubules, and if we combine it, giving us a length of 250 meters. And the seminiferous tubules, at first forming a straight tubule, then it forming the retitestes, and from retitestes it form the apparent tubules, and then the epididymis, and from epididymis it go into the vas deferens, and then it combine with the seminal vesicle and entering into the posterior urethra in the form of ejaculatory duct. And the seminiferous tubule is mainly lined by the Sartori cell, which help in the maturation process of spermatozoa. And it contain Sartori cell, that's why it is under control of PPSH, and Sartori cell help in spermatogenesis. The second portion is the interstitial tissue, which is just composed of 20 to 30%. In the interstitial tissue, the Leydig cell lies and that are responsible for testosterone production, and this testosterone production is under control of luteinizing hormone. So the interstitial tissue is composed of Leydig cell and that is under control of LH, while the seminiferous tubule is composed of the Sartori cell and that is under control of FSH and help in spermatogenesis.